This morning, our topic will be on trauma. To introduce myself, I'm Dr. Raimundo Resurreccion. I'm the head of the Surgical Intensive Care unit of the Quirino Memorial Medical Center. I likewise am the National Director for the Advanced Trauma Life Support program of the Philippine College of Surgeons, as well as co-chair of our trauma surgery and surgical critical care fellowship program, which is a program jointly delivered by Quirino Memorial Medical Center, by Jose Reyes Memorial Medical Center, and Rizal Medical Center. Without further ado, I'd like to introduce our speaker for this morning. Our speaker is a current fellow of that program that I mentioned, of the Surgical Critical Care and Trauma Surgery Fellowship Program. He is no other than Dr. Ivan Tan. He is a diplomate of the Philippine Board of Surgery and already finished his trauma fellowship under the FAST program at the Jose Reyes Memorial Medical Center. Ladies and gentlemen, may I give the floor to Dr. Ivan Tan. But before that, allow me to give you some house rules. Please make sure that you're muted throughout this Dr. Tan's presentation. Should you have any questions, please type them in the chat box and I will try to get back to you during or immediately after the presentation. Thank you very much, and I hope you will learn, and we hope that you can help improve our delivery of trauma care. Thank you. Ivan?
Thank you, sir, for that kind introduction. Let me just share my slides. Charlie. Good morning. For today's conference, in behalf of Quirino Memorial Medical Center, I'll be presenting the EHQUIP series. For today's topic, I will be discussing trauma, specifically T.E.A.M, or Trauma Evaluation and Management, Early Care of the Injured Patient. These materials comes from the American College of Surgeons and the ATLS. This trauma evaluation and management program provides a participant with an overview of the purpose and concept of immediate management of the injured patient and a basic understanding of the fundamental principles of trauma care, which includes rapid and accurate physiologic assessment, resuscitate, stabilize, and monitor by priority, prepare for transfer to definitive care, and teamwork for optimal and safe patient care. Upon completion of this program, the participant will be able to describe the principles of early care in multiply injured patients. Specifically, the participant will be able to describe fundamental principles of initial assessment and management, identify correct sequence of management priorities, describe appropriate techniques of resuscitation, recognize value of patient history, understand importance of injury mechanism, and identify concepts of teamwork in caring for the injured patient. Trauma is the leading cause of death in ages 1 through 44. Disabilities exceeds death by ratio of 3:1, and trauma-related costs per year is more than $400 billion in the US. And there is a lack of public awareness for injury prevention. Components to injury prevention includes analyze injury data, build local coalitions, communicate the problem, develop prevention activities, and evaluate the interventions. This illustration depicts trimodal death distribution. During the first peak of distribution occurs within seconds to minutes of injury. During this early period, deaths generally result from laceration of the brain, brainstem, hollow viscous, major vessels, and the other. Very few of these patients can be salvaged due to severity of the injuries, and only prevention can significantly reduce this peak of traumatic deaths. The second peak occurs within minutes to several hours following injury. The T.E.A.M prevention program focuses primarily on this period. Deaths occurring this period are usually due to subdural and epidural hematomas, pneumohemothorax, ruptured viscous, ruptured solid organs, and associated with significant blood loss. The first hour of care after injury focuses on rapid assessment and resuscitation, which are the hallmarks of trauma evaluation and management. The concept of the golden hour emphasizes urgency of successful management in order to optimize outcome of the injured patient, and is not intended to imply fixed time period, like for example, 60 minutes or 3 hours. In the third peak, occurring several days to weeks after the injury, death is most often due to sepsis and multiple organ system failure. The concept behind trauma evaluation and management is simple. The approach is to the injured patient is not the same as that of patient with previously undiagnosed medical condition. There are only 6 underlying precepts of trauma evaluation and management, which includes treat the greatest threat to life. Definitive diagnosis is less important. In the application of indicated treatment, detailed history is not essential to begin the evaluation of acutely injured patient. Third is the need for physiologic approach to the evaluation and treatment of the injured. Fourth is that injury kills certain reproducible time frames, thus time is of the essence. Fifth is to do no further harm. And sixth is teamwork. Teamwork with multidisciplinary team is required for team to succeed. The physiologic approach to evaluation and treatment of the injured patient follows primary survey in identifying and treating the greatest threat to life. Primary survey are as follows: A, for airway, which is spine protection; B, breathing, ventilation, and oxygenation; C, circulation, stop the bleed or stop the hemorrhage; D, disability, assess the neurostatus of the patient; E is exposure, but make sure to prevent hypothermia during this event. The team sequence, first is the rapid primary survey, which includes A, B, C, D, and E, plus the adjuncts to primary survey. After doing the primary survey, secondary survey is the next, and with reevaluation, and this time we do the complete history and PE and additional procedures like CT scan to evaluate the patient further. And if the patient is deemed safe for transfer, we transfer patient to a higher center for definitive care. Simultaneous primary survey and resuscitation of vital functions, and simultaneous secondary survey and reevaluation of vital functions. TEAM is also an acronym for Together, Everyone Achieves More. In ideal trauma system, trauma care is delivered by a multidisciplinary team following the same physiologic priorities presented in the TEAM program, yet more in parallel with another than in a series of critical intervention. The team leader manages the primary and secondary survey, ensuring linkages between evaluation and management. The airway manager focuses on providing and maintaining a patent airway, ventilation, and oxygenation. The nurse collects specific data For example, vital signs for trauma evaluation and management and monitoring activities in the resuscitation room. The assistant performs specific tasks such as removing the patient clothing, inserting intravenous catheter and administering fluids and obtaining blood and urinary specimen. Coordination with pre-hospital agency and personnel can greatly expedite the treatment in the field. Pre-hospital system should be set up such that the receiving hospital is notified before pre-hospital personnel transport the patient from the scene. This allows mobilization of hospitals, trauma team members, so that all necessary personnel and resources are present in the emergency department at the time of the patient's arrival. So we transport the patient to the closest appropriate facility, follow transport guidelines and protocols locally, online medical directions, doctor-to-doctor communication, and mobilization of resources in the emergency rooms, and periodic review of care. Advanced planning for trauma patients' arrival is essential. Ideally, a resuscitation area should be available for trauma patient. Proper airway equipment should be organized, tested, and strategically placed where it is immediately accessible. Warm IV fluids should be available and ready for infusion when the patient arrives. Appropriate monitoring capabilities should be immediately available. A method to summon extra medical assistance should be in place. A means to ensure prompt response by laboratory and radiology personnel is necessary, and transfer agreements with verified trauma centers should be pre-established and operational. Periodic review of care through quality improvement process is an essential component of the hospital's trauma program. All personnel who have contact with the patient must be protected from communicable diseases. Most prominent among these diseases are hepatitis, HIV. That's why the Center for Disease Control and other health agencies strongly recommend the use of standard precaution, which includes cap, gown, gloves, mask, shoe covers, goggles, and or face shields. Sorting of patients according to priority with regards to the primary survey, the available resources of the agency or the institution, and other factors like the severity of injury or salvageability of the patient. Priorities are the same for all, whether it be adult, pediatrics, pregnant women, or elderly patient. Again, primary survey includes airway with C-spine protection, breathing, or identifying life-threatening injury to the chest, which includes tension pneumothorax, cardiac tamponade, massive hemothorax, circulation or stopping the hemorrhage, disability or assessing neurologic status of the patient, exposure, environment, and body temperature to avoid missed injuries. These are special populations which are identified, which includes children, adult, elderly, and pregnant women. Trauma is the leading cause of death in pediatric age group. Anatomic and physiologic differences from adult include both developmentally immature features of the child and a vigorous compensatory response to major trauma, which is relatively short-lived due to limited compensatory reserves. The size, dosage, equipment, surface area, and psychology is different from that of the adult. In managing the airway and ventilation, it must be remembered that the larynx is cephalad and anterior, and the trachea is relatively short, making intubation more difficult. The mobile mediastinum and pliable chest wall result in greater susceptibility to tension pneumothorax and pulmonary contusions. Circulation, vascular access, fluid volume, vital signs, and urinary output. As for neurologic, monitor for vomiting, seizures, and decreasing level of consciousness. And Take note that the pediatric age group, the skeletons are immature and observed for the patterns of fracture. Another special population are pregnant women. The priorities of care for pregnant women are similar to those of non-pregnant patient, but the anatomic and physiologic changes of pregnancy may modify the patient's response to injury. There is a need for fetal assessment for this population, and the first priority is maternal resuscitation. And variation in the position of the uterus with gestational age and physiologic anemia resulting from increase in plasma volume relative to red blood cell mass, the characteristic of hyperventilation with low arterial PCO2, decreased gastric emptying time, the supine hypotension resulting from compression to the vena cava by the gravid uterus, the risk of isoimmunization in Rh-negative mother, and extreme sensitivity of placental circulation to maternal hypovolemia are some of the important considerations in the approach to managing injured pregnant patient. The elderly age group are the fifth leading cause of death in trauma patient. Due to their diminished physiologic reserves and response, multiple comorbidities with maintenance medication like blood thinners, and outcome depends on early and aggressive care. As for the airway, assess for airway patency, note for any snoring, gurgling, stridor, rocking chest wall motion, and maxillofacial trauma or laryngeal injury. Caution for C-spine injury. Maneuvers to open the airway is chin lip with modified jaw thrust, look, listen, and feel, remove any particulate matter in the oral cavity, do or give definitive airway if necessary, and reassess patient frequently. As for the breathing, observe for chest rise and symmetry. Observe for air entry and the rate and effort of patient's breathing, as well as the color and sensorium of the patient. Watch out for tension and open pneumothorax on this area. So administer supplemental oxygen, ventilate patient as needed. For tension pneumothorax, do a needle decompression followed by closed tube thoracostomy. And for open pneumothorax, do an occlusive dressing followed by closed tube thoracostomy, and then reassess patient frequently. As for the circulation, there are group of populations that we need to be cautious. This includes children, elderly adults, athletes, pregnant patient, and those with maintenance medication. Children usually have abundant physiologic reserves and often demonstrate few signs of hypovolemia even after severe volume depletion. Elderly, on the other extremes, have limited physiologic reserves, while well-trained athletes have a vigorous compensatory mechanism and is normally relatively bradycardic and does not demonstrate the usual level of tachycardia with blood loss. For pregnant patient, altered response to volume loss due to physiologic hypervolemia of pregnancy and catecholamine-simulated vasoconstriction in the placental circulation, which requires significant volume loss before any signs of hypovolemia may become apparent. And for those patients with or on maintenance medication, that could alter the response to injury. If the shock is non-hemorrhagic, then obstructive causes of shock must be considered, which includes tension pneumothorax and cardiac tamponade. Hypotension with bradycardia should suggest the presence of neurogenic shock. Although septic shock occurs in trauma, it is usually a late manifestation Neurogenic shock occurs when an injury affects sympathetic pathway, resulting in loss of sympathetic tone to the vessels and failure to produce tachycardia from sympathetic pathway. Therefore, it is manifested by hypotension with bradycardia and warm extremities, which are direct contrasts to the patient in hemorrhagic shock. Hypotension following injury must be considered to be hypovolemic in origin until proven otherwise. Rapid and accurate assessment of the injured patient's hemodynamic status is therefore essential. The elements of clinical observation that yield key information within seconds are level of consciousness, skin color, pulse rate, and the character of the pulse. In assessing organ perfusion, signs accompanying decreased blood flow resulting from decrease in the cardiac output should be sought. For example, tachycardia, full extremities from vasoconstriction, narrowed pulse pressure, and in later phases, a fall in the mean arterial blood pressure. Ideally, diagnosis of shock should be made prior to the development of obvious hypotension. As mentioned earlier, this population has different physiologic response to trauma. The children usually again has abundant physiologic reserves, while the elderly on the other extreme has limited physiologic reserves, while athlete has a vigorous compensatory mechanism, which are relatively bradycardic and does not demonstrate a level of tachycardia with regards to blood loss. And pregnant patient, due to physiologic hypervolemia of pregnancy and catecholamine-stimulated vasoconstriction of placental circulation, requires significant volume loss for hypovolemia or hypotension to occur. Bleeding should be considered external or internal. External hemorrhage is identified by physical examination and promptly controlled by direct pressure in the primary survey. As indicated previously, an internal source of hemorrhage may be identified by combination of history, physical examination, simple investigation such as chest X-ray, X-ray to the pelvis, fast ultrasound, and CT scan for those who are not hemodynamically compromised. A large bore IV access is established for fluid resuscitation, beginning with Ringer's lactate or normal saline, followed by blood if necessary. On this table, we can see the levels or class of shock. For class 1, at least 15% of blood loss. For class 2, at least 30% of the blood is lost. For this type of shock, class 1 and class 2 only requires crystalloid transfusion. But for class 3 and class 4, for class 3, the estimated blood loss or blood volume loss is about 30 to 40% and more than 40% for class 4, which may require blood transfusion. For tension pneumothorax, consider needle decompression and then followed by tube thoracostomy. For massive hemothorax, give volume resuscitation and tube thoracostomy. And for cardiac tamponade, do a pericardiocentesis and direct patient to the OR for operative repair. For D, disability, assess the neurologic status of the patient, which includes the GCS, pupillary response, and note for any lateralizing signs. During this period, observe for any neurologic deterioration of the patient. So for the GCS score, the Glasgow Coma score provides a quick measure of level of consciousness. Eye opening scored from 4 to 1, and best motor response is 6 to 1. And for the verbal response is scored at 5 to 1. The GCS score is the sum of these three, with the best possible score being 15 and the worst possible score is 3. As for the exposure, Completely undress the patient, remove helmet if there's any, look for visible or palpable injuries, lag roll the patient, but make sure to protect the spine. And during this period, when undressing the patient, prevent patient from any hypothermia. If in doubt, establish a definitive airway. Oxygen for all trauma patient. Chest tube may be definitive for chest injuries. Stop the bleed if there is any obvious bleeding. Insert 2 large bore IVs and prevent hypothermia. Adjuncts to primary survey includes urinary catheter. Watch out for any blood coming out from the catheter. It is used to decompress the bladder and monitor the urinary output hourly. Note for any decrease in the urinary output. But prior to insertion of urinary catheter, make sure that there is no blood at the urinary meatus. There is no perineal ecchymosis or hematoma or any high riding prostate, because this may indicate that there is a urethral injury. An insertion of urinary catheter will further disrupt the urethra. Gastric catheter or nasogastric tube. Watch out for the output if it is bile or blood. It is used to decompress the stomach. Prior to insertion, again, watch out for any CSF leak, specifically rhinorrhea and otorrhea, periorbital ecchymosis, mid-phase instability, or hemotympanum. Because these signs may indicate a basilar skull fracture, and insertion of nasogastric tube is dangerous, and because it may lodge into the brain. So if the following signs and symptoms are present, insert the gastric catheter through the mouth or orogastric insertion. Adjuncts to primary survey for the monitoring, monitor vital signs, the arterial blood gases, ECG, pulse oximetry, end-tidal CO2, and for the diagnostic, chest and pelvic X-ray, C-spine X-ray when appropriate, do a fast ultrasound and DPL. And if there is a need for transfer the patient immediately, even without doing a diagnostic procedure. Secondary survey does not begin until primary survey is completed. Resuscitative efforts are well established and the patient is demonstrating normalization of vital function. Key parts of secondary survey includes the ample history, complete physical examination from head to toe, complete neurologic examination, special diagnostic procedures, and reevaluation. The ample history are as follows: A for allergies, M for medications, a past illness and or pregnancy, last meal, and events or environment during the injury. During the secondary survey, the mechanism of injury is identified. The patient condition is greatly influenced by the mechanism of injury. Pre-hospital personnel can provide valuable information on such mechanism and should report pertinent data to the examining doctors. Some injuries can be predicted based on the direction and amount of energy force. And usually it is classified into 2 broad categories, the blunt and the penetrating type of mechanism. Burn injury. Inhalational injury, if there is any identified inhalational injury for burn patient, intubate and administer 100% oxygen. Administered 2 to 4 ml per kilo per TBSA within 24 hours, plus maintenance fluid in pediatric age group. Monitor urinary output for adequate resuscitation and expose and prevent hypothermia. And for chemical burn, brush and irrigate the area that is involved. This illustration shows the rule of nines in estimating the total body surface area of burn patient. The most significant local cold injury is frostbite because of its associated risk of tissue and limb loss. And the most significant generalized cold injury is hypothermia because of its major systemic effects, which can be lethal. Frostbite requires removal from cold environment, rapid rewarming with moist heat, and waiting for demarcation before debridement. Hypothermia treatment also requires removal from cold environment, the use of warming devices that may be passive or active while monitoring temperature, hemodynamics, and coagulation parameters. Unless hypothermic patient has a previous cardiovascular or hypoxic insult leading to hypothermia and loss of vital function, patient cannot be pronounced dead until warming techniques are instituted. And the patient's core temperature is reversed because with rewarming, the lack of vital signs also can be reversed. So the patient is not declared dead until warm and dead. So for the secondary survey, a detailed history and physical examination from head to toe. Do a complete neurologic exam, GCS core determination, comprehensive eye and ear exam. Watch out for the unconscious patient, those patients with periorbital edema and those with occluded auditory canal or those with hemotympanum or blood on the ear canal. For maxillofacial trauma, note for any bony crepitus or instability, palpable deformity. Do a comprehensive oral and dental exams. This is a potential for airway obstruction or cribriform plate fracture, and watch out for frequently missed injuries. Patient with fractures to the mid-face may have fracture in the cribriform plate, and for this patient, gastric intubation should be performed via the oral route. As for the C-spine, palpate for any tenderness. Note for any complete motor and sensory loss. Note for the deep tendon reflexes and do a C-spine imaging. Should be worried about the injury above the clavicle and those patients with altered level of consciousness and other severe or painful injuries. As for the neck, the mechanism could also be blunt and penetrating. Note for any airway obstruction, which can be noted through hoarseness. Watch out for crepitus, hematoma, stridor, and bruit. Note for any delayed signs and symptoms, progressive airway obstruction, or any occult injuries. As for the chest, contusion and hematomas of the chest wall should alert the doctor to the possibility of occult injury. So inspect, auscultate, palpate, and percuss, and then reevaluate frequently. Do a chest X-ray to note for any fractures, pneumothorax, or hemothorax. And watch out for an increased chest tube drainage if chest tube was inserted immediately prior to examination. As for the abdomen, close observation and frequent re-evaluation of the abdomen, preferably by the same observer, is important in managing blunt abdominal trauma. Over time, the patient's abdominal finding may change. Fractures of the pelvis or lower rib cage may also hinder accurate diagnostic examination of the abdomen because pain from these areas may be elicited when palpating the abdomen. Excessive manipulation of the pelvis should be avoided. A pelvic X-ray performed as an adjunct to primary survey and resuscitation and should be used as a guide for identification of pelvic fracture which can be associated with significant blood loss. Injury to the retroperitoneal organs may be difficult to identify even with the use of CT scan. Aloviscus and pancreatic injury are a classic example of retroperitoneal injuries. For female patient, a vaginal examination is an essential part of secondary survey. The doctor should assess the presence of blood in the vaginal bulb and vaginal laceration. Additionally, pregnancy tests should be performed on all women of childbearing age. Female urethral injury, while uncommon, does occur in association with pelvic fracture and straddle injuries. And when present, it is difficult to detect. As for the rectum, assess for sphincter tone, high riding prostate, pelvic fractures, rectal wall integrity, and blood on examining fingers. Although most musculoskeletal injury are diagnosed and treated during the secondary survey, treatment may be required during the primary survey when life-threatening hemorrhage or limb-threatening injury results from vascular injury or ischemia from compartment syndrome. During secondary survey, the extremities should be inspected for open wounds, contusion, deformities, palpation of bones, and examination for tenderness or abnormal movement aid in the identification of occult fractures. And additionally, assessment of peripheral pulses aids in the identification of any vascular injuries. Compartment syndrome may be present in patients with ischemic or crash injuries to distal lower extremities. This complication must be suspected in any patient who presents with such injuries, particularly if the patient is hypotensive or has altered level of consciousness. And we should not forget to assess the patient's back. As for the pelvis, pelvic fracture can be suspected by identification of ecchymosis over the iliac wing, pubis, labia, or scrotum. Other cues include an increase in the width of the pubic symphysis and leg length inequality. Pain on palpation on the pelvic ring is an important finding in alert patient. Mobility of the pelvis in response to gentle anterior-posterior pressure with the heel of the hands on both anterior iliac wing, iliac spine, and symphysis pubis can suggest pelvic ring disruption in unconscious patient. Blood loss from pelvic fracture with increased pelvic volume can be difficult to detect and control. The fatal hemorrhage may result. A sense of urgency should accompany the management of these injuries. Fluid resuscitation and restriction of pelvic volume by pelvic binder or pelvic sling and external fixation device are key elements to manage this type of injury. Patient failure to respond to this measure requires consideration for angiography with possibility of embolizing the bleeding vessels. Blood loss from pelvic fracture with increased pelvic volume can be difficult to detect and control. As for the CNS, frequently reevaluate the neurologic status of the patient, prevent secondary brain injury, do an imaging like CT scan if deemed necessary, and consult our friend from neurosurgery if early. A comprehensive neurologic exam includes not only motor and sensory evaluation of extremities, but also re-evaluation of the patient's level of consciousness, pupillary size and response. GCS score facilitates detection of early changes and trends in the neurologic status of the patient. So we must refer this type of patient early to our neurosurgery friends or colleagues. Any evidence of sensation, paralysis, or weakness suggests major injury to the spinal column or peripheral nervous system. Neurologic deficits should be documented when identified. This is especially important when transfer to another facility or doctor for specialty care is necessary. Immobilization of the entire patient using a long spine board, a semi-rigid cervical collar, and other cervical immobilization device must be maintained until spinal injury can be excluded. Adjuncts to secondary survey includes additional blood tests, urinalysis, X-rays, CT scans, urogram or angiogram, ultrasounds, echocardiogram, bronchoscopy, and esophagoscopy. During secondary survey, it is not necessary to do all this barrage of procedures. If the patient requires transfer, we may transfer patient immediately. So after doing the primary and secondary survey, reevaluate again the patient to avoid missed injuries. We must have a high index of suspicion. Again, we must frequently reevaluate our patient and do a continuous monitoring and rapidly recognize patient vital signs for any deterioration. Relieve pain and anxiety appropriately. Administer pain medication IV intravenously, and careful patient monitoring is essential. A pre-established criteria for inter-hospital transfer help determine the level, pace, and intensity of initial management of multiply injured patient. These criteria take into account the patient physiologic status, obvious anatomic injury, mechanism of injury, concurrent disease, and factors that may alter the patient's prognosis. The emergency department and surgical personnel should use this criteria to determine if the patient requires transfer to a trauma center or closest appropriate hospital capable of providing more specialized care. Transfer process should be initiated as soon as the need is recognized. Patient transfer is not delayed to obtain definitive diagnostic tests. Instead, time before transfer focuses on the patient's evaluation and resuscitation, as well as direct doctor-to-doctor communication at the receiving hospital. Emergency preparedness. The following 4 steps constitute the fundamental elements of all disaster and emergency preparedness and response effort. The basic and readily understood approach to mass casualty events is a key to effective disaster and emergency management. An incident command structure known to all personnel within the healthcare facility is vital to operational success during disaster, whether internal or external. Establish a clear line of responsibility and authority for all hospital personnel, thereby maximizing collaboration and minimizing conflicts during typically chaotic first minutes and hours of disaster emergency response. Whether the disaster is a multiple casualty incident that strains the resources of the institution or mass casualty event that overwhelms them, a method of rapid identification of victims requiring priority treatment is essential. Most triage schemes utilize color-coded tags to indicate acuity. Red for critical, yellow for urgent, green for delayed, and black for expectant patient. Controlling the flow of information, equipment, and personnel is of paramount importance in the disaster response, and these are the issues most often cited in after-action reports as the cause of mismanagement. The injured patient must be evaluated rapidly and thoroughly. The doctor must develop treatment priorities for overall management of the patient, so no steps in the process are omitted. and adequate patient history accounting of the incident are important in evaluating and managing trauma patient. Evaluation and care are divided into the following phases for the purpose of discussion to provide clarity. In actual situation, assessment, resuscitation or treatment, re-evaluation and diagnosis occur simultaneously, but priorities should not be changed. In summary, there is only one safe way: do no further harm, treat the greatest threat to life first, and of course, teamwork, a collaborative teamwork. Thank you. That's all for my discussion for today.
Thank you, Ivan. At this point, are there any questions from the audience? I don't see any questions so far in the chat box. If you have questions, please raise your hand on Zoom, and we will and you can unmute yourself and ask the question directly to Dr. Tan. If you're the shy type, you can just type your question, and I will do the honors of asking your question to Dr. Tan. Thank you. Thank you, Dr. Tan. That was quite a long and very detailed lecture. This material, again, is coming courtesy of the American College of Surgeons Committee on Trauma. These are the same folks who have brought you the Advanced Trauma Life Support course. For those of you who have not read my announcements in the chat, if there are doctors in this Zoom meeting who are interested in joining the Advanced Trauma Life Support course, you can look at the chat for the contact person. That is Mr. Severo Ruiz, who is the ATLS course coordinator, and he can get you into one of our upcoming courses. For the nurses, the ATLS, at least as far as the courses offered in the Philippines, are only open to the doctors. However, for the nurses in the room, particularly if you're working with trauma patients, whether in the ER or in the district hospitals, you can also contact Mr. Ruiz, because we need audits. These are the nurses who observe during the course and help us out by serving as assistants during the skills stations and the initial assessment station, as well as volunteering to be live patient models or moulages. So you're more familiar with how we do things at ATLS, and to sort of synthesize everything that Dr. Tan has presented, allow me to share you with a video that we usually present during the course. And maybe the details fall into place as you see it run through as a process in assessing and treating your trauma patients. Let me know if you can see it, Ivan. Is it?
So Tracy, what do we got coming in?
Does that work, Ivan?
Yes, sir. Ongoing.
Works for you. Okay. I'll put it back out. Okay.
So Tracy, what do we got coming in?
Yeah, Dr. Boyer sounds pretty sick. He's an 18-year-old motor vehicle crash victim, unrestrained driver. Sounds like he's a little unstable in the field. Heart rate is in the 120s. Blood pressure is 90/40. He's got an obvious left femur fracture. They have him in a hair traction splint. He's backboarded, collared. They have him on some oxygen. It sounds like his O2 sats are in the 88 to 93%, and his GCS is poor.
So minimally responsive, and they've got some oxygen going.
They have
and
oxygen.
One IV?
One IV, I think 18 in the right AC.
All right. So it sounds like this guy is pretty injured. We're going to need to take care of a lot of things. It sounds like he has an airway problem. It sounds like he's in shock. So there are a couple quick things we need to do very quickly when he gets here is let's make sure that we got our airway stuff ready to go. It sounds like you need to be intubated. So we got everything we need?
I got everything out.
All right. And Betsy, it sounds like he's only got one IV. So when he arrives, what I'd like you to do is put a second IV in on his other side that it doesn't have one. We'll get some blood out of that when we do it. Also, if you would call the lab and x-ray before he gets here, make sure they come and help us out. And Tracy, when he gets here also, I'm going to look at his airway, and while I'm doing that, can you put him on a monitor and a blood pressure cuff?
Yes, sir.
And let me know immediately what the vital signs are so we can go from there. And I guess the other thing we ought to think about is this guy's probably bleeding a fair amount from the sounds of it, so let's notify the blood bank, and let's get the massive transfusion protocol on standby and make
Okay.
sure that we got that ready to go. Also sounds like this guy is a little too sick for us to keep here. So once we figure out what's going on, let's get the trauma center on the phone because I'd like to talk to him and get him transferred, okay?
Yes, sir.
All right. Any questions?
Nope, right
All
here.
right, let's do it.
This is Garrett. He's 18 years old. He's an unrestrained driver in a single vehicle MVA into a tree. About 10-minute extrication. He's a GCS of about 8. Has a head injury up here underneath the gauze and has an open femur fracture with some minor bleeding.
He was in motor vehicle collision
Yes,
into a tree,
Yes,
prolonged extrication.
10 minutes.
He's unrestrained,
unrestrained.
and you said he's got an obvious head injury
Obvious head injury.
and an obvious femur fracture.
Open femur fracture with some
Okay,
bleeding.
and that's all you see right now.
The bruising to the left chest as well.
And his last set of vitals.
Blood pressure was 90 by PAL. He was 120 sinus tap on the monitor. Respiratory rate was about 12. Was clear bilaterally. And he's been unresponsive for us.
Any other issues?
Not that I know of.
All right, thank you very much.
Thank you.
All right, guys, this guy looks like he's got a lot of injuries, and let's do this in a nice systematic fashion. We're going to start with our ABCs. So Tracy, while I'm assessing the airway, I want you to put some leads on. Let's get a blood pressure. And Betsy, if you can come over here on this side and help me with the airway. Looks like he's breathing about 20 times a minute. Sir, can you open your eyes? Sir, what's your name? Looks like he's not responsive at the moment. He's got some obvious facial trauma, and it looks like he's not breathing real well. He's a little bit blue.
O2 sat 82%.
O2 sats 82%, so we're going to need to intubate him. So what I would like you to do, Betsy, is I want you to hold C-spine precautions here. I'm going to take the C-spine collar off,
Got C-spine.
and I'm going to put in an oral airway in here. See if we can get a little bit better. All right, let's put this oral airway in. Let's go ahead and bag him here. Responsive. It looks like he's going to need to be intubated. Do we have our intubation stuff ready?
Everything's right behind you, ready to go.
All right, can you bag him here while I grab that?
I got it.
Can you come off for a second? Let me just take a look here. Looks like we got a little bit of blood in there. Let me suck that out. All right.
That's your suction.
Suction. All right, good. Great. All right, let me just take a peek here.
Let me know if you want some cricoid, Dr. Boyer.
Yeah, a little cricoid pressure would be great. Thank you. All right. See his cords, tubes going in. Great.
Good color change. Good
Right.
color change.
All right, let's get him hooked up to a ventilator. In the meantime, let's put the C-spine collar back on, protect the C-spine. All right, and let me take a listen to his lungs. Betsy, there's a little bit of bleeding there. Put some pressure on that if you would.
Can we call for respiratory and a ventilator, please?
I got good breath sounds on both sides. A little bit less on the left and the right. He's got some bruising on his left chest. So let's see what we got. His airway is taken. We've got him as intubated. His pulse ox has come up to 96%. What are our vital signs doing?
Looks like his heart rate's 115 and his blood pressure's 90/42.
All right. So it looks like he's a little bit in shock. We've got airway and breathing taken care of. Is he
I have
bleeding
one
anywhere
IV here.
actively?
Would you want a second one?
So he's bleeding down here on the leg. Can we get some more help? Hey, Will, can you help us?
Yep, come on.
Dr. Boyer, would you like a second IV?
Yes, let's start a second large bore IV, and let's hang normal saline. And how much IV is go fluid? Put some pressure on that if you would, please.
Yep.
You keep bagging. Start a second IV over here, Tracy, if you would. And I think this guy's going to need some blood, so let's call the blood bank and get a massive transfusion protocol going.
Okay.
All right, so we got control of the bleeding there, control of the bleeding there. Let me feel his pulses down here. I think his traction splint seems to be working. I think he's got good pulses here with some bleeding there. It looks like an open femur fracture. I don't see any obvious bleeding on his chest. His abdomen is soft. His pelvis is not stable. I think he's got a pelvic fracture, so you
Okay.
could have significant bleeding from there. So definitely this guy's going to need some blood, so let's make sure we get some blood products for him. In the meantime, let's expose the patient. Is that bleeding seem to be taken care of there? Did you wrap that, Will?
Yep, looks pretty good now.
All right, can you go ahead and get him exposed? Take off the rest of his clothes there. And once we get him exposed, let's make sure we get some warm blankets to cover him back up so we don't get hypothermic. Let's do a disability exam. All right, sir, can you open your eyes?
Blood is running.
He opens his eyes to pain. That's a 2. Wasn't verbalizing, so that was a 1. Let me see if he responds to painful stimuli. He's localizing, so that's a 4.
Ventilator.
It looks like he's got a significant head injury, and we're going to need to get him to a neurosurgeon. In the meantime, let's keep oxygenating him. What's his blood pressure doing now? Looks like, let's see, it's up to 105 systolic. Heart rate's down to 100. We also, I think we're going to need to wrap this pelvis with a sheet. Can you grab a sheet for me there, Will? Let's go ahead and make sure we wrap this pelvis. And we're going to need to log roll him. So we got him hooked to a ventilator.
Coming up.
All right, this is going to be on your count. You count it down for us on the count of 3.
Secure 1, 2, and 3.
All right, let me get this backboard out.
Watch the IV.
And I'm going to examine the spine here to make sure there's no step off. Feels like there's no step off here. Let's do a rectal exam. I need some jelly for that. All right. All right. He's got good rectal tone. While I've got him up here on the side, let's put the x-ray plates in to get a chest and a pelvic x-ray.
Watch the IV, sir.
All right. And let's bring it back on your count again.
Ready? 1, 2, and 3. And 1 more.
Can we call for x-ray, please? All right, we'd like a chest and a pelvis.
Yes, sir.
All right, guys, let's reassess what we've done so far. We've done our ABCs. We've got him his airway control. We've assessed his breathing. He's got good breath sounds, a little bit of diminishment on the left-hand side. We know that he has a pelvic fracture and some bleeding from an open femur fracture. We've reduced that. We've got good pulses. He's also got some bleeding from his scalp and an obvious head injury. So this guy, clearly, we need to transfer him to a trauma center. So what I'd like to do at this juncture is we'll take a look at those x-rays we shot. I want you to put an OG tube in because of concern for a head injury, and I want you to put a Foley catheter in a moment here. And then what we'll do is reassess the patient. What are his vital signs right now?
Currently, his O2 sat is 96%. His blood pressure is 110/64. Heart rate is 97.
And we've given him how much fluids?
500 cc's of saline and 1 unit of Pax, 2 units Paxil.
2 units Paxils and 500 cc saline. So it sounds like we've stabilized him a little bit. We've got a sheet around his pelvis here. We're going to get him packaged up for the trauma center. So Betsy, could you get the trauma center on the phone for me? I need to talk to them and arrange transport. And while we're doing that, we're going to do a detailed secondary survey. We're going to do a head-to-toe, fingers and tubes in every orifice exam. And we'll get him all packaged up to go. And also, Betsy, could you make sure that the x-ray department makes copies of all of our x-rays so we can send them along? Tracy, it looks like we've got our x-rays back. We've got a chest here. Looks like he's got some rib fractures here on the left side and some haziness. He's probably got a pulmonary contusion. And his pelvic film, he's got a acetabular fracture, a pelvic fracture. That confirms, I think, what we think is going on with his blood loss. Let's get copies of these x-rays made and send them so we can send them on to the next hospital with him, okay? Dr. Brazell, hi, this is Mark Boyer from Mary Washington. I got a patient that I need to transfer you to. It's a 18-year-old young male who was involved in a high-speed motor vehicle collision. He ran his car off the road into a tree. There was significant damage to the front end of the car. He was unrestrained. Apparently he was unresponsive at the scene. We intubated him. He does have some diminished breath sounds on the left side with some rib fractures, and also he's also got what appears to be a pulmonary contusion. He's also got bleeding from a scalp wound. He's got an open femur fracture on the left side. We've immobilized it. He's also got a pelvic fracture. We've got him in a pelvic sling right now. We've given him 2 liters of fluid. He's gotten 2 units of blood. His blood pressure right now is 110/50. His heart rate is 110. And we've got him intubated on 100% oxygen with 98% saturation. Yeah, I think that he probably needs to come by air. So if we can make the arrangements to send the helicopter, I'd appreciate it. And I will package him up. I'll send some blood products and we'll send the x-rays as well. And we'll await your arrival. In the meantime, I'll get some x-rays of his femur and everything else, but we won't delay his transport. Any other questions? No, thanks. Thank you very much.
Okay, at this point, I'd like to open the floor for any questions. And if you look at their chat box, I've actually taken the liberty of putting up the material that we are using or that we have presented this morning for your reading pleasure, and hopefully you don't only read the material, but rather you live and breathe this material in the way you treat your trauma patients. Any questions for Dr. Tan? Any questions? Ivan, can you turn on your camera? No questions. It's already 10 o'clock. Unless you have any special requests as to what you want us to present. From the Petro, is there anything else that we need to ask, or do you want from the Petro? Is there any feedback form that they are linked that you need them to fill out? Okay, kindly, the Petro will post it here on the chat. So we would appreciate that you wait for that link. So if you have any feedback or questions, we do welcome any questions. For your referrals, we would appreciate if you could coordinate your transfers so we know what's coming to Quirino, so we can better assess and prepare for your patient's arrival. Thank you. Ivan, any last messages? Takot sila o masyado kang mabilis walang nagtanong
Again, I would like to thank you, sir, for this opportunity to present in behalf of Surgical Critical Care Program of Quirino Memorial Medical Center. I am proud to represent our section in this kind of event. Again, thank you.
Okay, I guess I'm here to wrap up. If there are no questions, I would say no other, but there was no question ever. So if there are no questions, I guess that we'll call it a morning already. Please go before you sign out, and you were paying attention to the lecture. Please take note of the postings on the chat before we close the meet, so that if there's information that you need, you can already copy it now. The number of our course coordinator is in the chat, and please fill in your attendance and program evaluation. It's now on your chat.